started. My name's Rebecca McGoldrick, for those of you guys who don't know me, and Denise and Michelle and I wanted to do this grand rounds because we wanted, we know that we have a lot of residents interested in these global health trips and international electives, and we wanted to kind of get that information out there to the other residents about what's available and who to contact, and sort of like highlight the experiences that the residents have had. So our mission statement is to promote global patient advocacy by addressing perioperative needs in low-resource environments through innovative global health education, training, and translational research. We have 2 board-approved resident rotations. One is at the University of Rwanda, and one is at the University of Zimbabwe. They're both about 2 to 4 weeks that we take each year. The ASA has a Global Health Outreach Resident International Scholarship where they send residents to Ethiopia, and they awarded 8 residents that last year, and 2 of those 8 were Stanford residents, and they're going to kind of talk about their experiences with that as well. And then 2 more of our residents were awarded that scholarship for next year, so congratulations to them. We have the Global Health Fellowship in the Anesthesia Department. We recently received a grant and brought one of our collaborators from Zimbabwe here for 2 weeks last summer to kind of get a better idea of what our educational and clinical resources are and how to adapt those so that they're relevant and useful to their residency program back in Zimbabwe. We also have several faculty members who take mission trips throughout the year to Nicaragua, Vietnam, Nigeria, Guatemala, Cambodia, and Ecuador. We didn't have a chance to talk about those trips, though, today, just for the sake of time. We kind of focused on the longer trips. And then we know that we have a continued interest in this because Michelle sent out a survey recently to the medical students who applied to Stanford for residency. And 80% said that they plan to participate in a global health experience during residency. 61% said that they would be interested in a global health track. And then about half of them said that they would probably not pursue it if they had to use their own vacation time or had to fund it themselves, which we've been fortunate that most of the residents haven't had to do that. Some of the research that we've done, I mentioned the grant that we got earlier. We did the flipped classroom technique with the Zimbabwean anesthesia residents about 1.5 years ago. That was recently presented at a conference. We are compiling a global health database to try to get all of the information about the trips in one place so that that's available to the residents so they know who to contact, what the trip is like, kind of what to expect when they go. And then we also do some research mentorship with the Zimbabwean and Rwanda residents. We've updated the website, got lots of new pictures, more useful links, more information on it, so you can check that out. And then we're also on Instagram, so if you want to follow us. And with that being said, I'm going to let Anne get started talking about our trip to Zimbabwe this year.
Hi, good morning. My name is Anne Ng. I'm one of the CA3s, and I'm just going to start off our resident and fellow reflections about our global health trips. I kind of put the lineup for today, so 4 of us are going to discuss some of the rotations that we've been on. And I think Rebecca already mentioned the database that we're kind of putting together. And I think really as a resident that was interested in global health and trying to figure out what everybody else was doing and things like that, I think this will be helpful. On the website, we also put a map of all the different places that people have been. So 4 of us are talking today. Double that number have been on trips this year. So definitely a lot of different people doing really cool things. So I'm going to start off talking about Zimbabwe. My faculty mentor was Rebecca, Dr. McGoldrick, and I went on this rotation late August, early September of my CA3 year. A little bit about anesthesia training in Zimbabwe. So Zimbabwe is a country in sub-Saharan Africa, which you see right here. A country of 13 million people, about 3 million people live in the capital city of Harare, and 1 medical school in the whole country, the University of Zimbabwe, through the University of Zimbabwe College of Health Sciences. And through that, 1 anesthesia training program throughout the whole country. So the main theme that you're going to hear that we're learning about that we don't quite experience at Stanford as residents in the global health curriculum is limited resources. And I kind of use this graph here to kind of really exemplify this, looking at a study that looked at physician anesthesiologists per capita. Zimbabwe has about 0.3, which for low middle income countries, a study by Dr. McQueen showed that's actually high, like the highest in a lot of the low middle income countries that we survey, while the US looking at kind of standard numbers for anesthesiologists have about 9.4. So there's definitely limited personnel. In Zimbabwe itself, there's very limited funding for academic physicians, and the attendings are actually called consultants. And so while they have educational duties, to even make a living in Zimbabwe, a lot of times they're actually working in the private sector in addition to their academic duties. So that altogether, I wanted to show that they're just basically very limited personnel and educational resources, and the goal of my rotation there was to serve as an additional educational resource for the anesthesia trainees. So a little bit about the history of Stanford and in our partnership with the University of Zimbabwe. I think we also have someone from CIGH, which has kind of helped us in this partnership. But in 2010, the NIH established a partnership initiative called the MEPI, the Medication Education Partnership Initiative, between 11 sub-Saharan African countries and academic centers in the US. So for Zimbabwe, the Stanford and University of Colorado partnered with them, and the real goals of all this funding money was to improve medical education, strengthen medical research and clinical training. So all the departments across Stanford, including surgery, especially initially psychiatry and cardiology, got a lot of funding to kind of help develop the programs at University of Zim. And from the anesthesia perspective, Drs. Anna Crawford and Vanessa Moll in 2013 went to Zim for the first time, kind of conducted a needs assessment of the anesthesia trainees and the registrars, which are basically anesthesia resident equivalents. And then later, Dr. McGoldrich, who was my mentor for this project, as a fellow, went and focused on some of their needs that were identified during the needs assessment, which was really the flipped classroom teaching model and video lectures there. So kind of to emphasize, previously, because of the limited personnel and just resources there, really training that the anesthesia residents have there are really through textbooks. And I feel like all the residents there they had such great textbook knowledge. They probably read all the textbooks twice over and kind of could quote all these things from the textbooks, and really traditional lectures, so PowerPoint lectures, just speaking to residents. And so what they wanted, and what kind of the needs assessment showed, is that they wanted more case-based learning, more video lectures they can access for home, simulation development, so going through case scenarios and simulations, and also because how they use the English model of teaching, they wanted more help with research project mentorship and collaboration, because every anesthesia registrar that graduates there needs to have a thesis project in a research kind of topic that they're writing about. So my rotation itself focused on more didactic teaching. It was a 4-week trip, ABA approved rotation. The lectures that I developed are based on the needs of the senior registrars. I was actually there about 2 months before their final exams. So they really wanted to learn about and talk about cases that they didn't usually see, like cardiac anesthesia. They don't do bypass cases, but for their exams, they would have to know about that. So they wanted to talk through, they had read all the textbooks. They wanted to talk through cases and just learn a little bit more from the perspective of if they were doing the case. And then, so cardiac anesthesia and neuroanesthesia were some of the big topics that they had questions about, specifically because they read everything in the textbooks about what we should do, neuromonitoring, different things, but they didn't actually have those resources there. So it was great to hear from someone that practiced in that setting of what Miller's textbooks talked about. So, and then pediatric anesthesia, which they saw a lot of, but wanted to know more about as well. So I definitely had some challenges of teaching in Zimbabwe. Not have ever gone to Africa or done any teaching abroad, just the uncertainties in the areas of need. I think because in the past we had a needs assessment to kind of show these are the topics that residents are really interested in. They want to learn more about procedures, cardiac, and different things. When I got there, that was a little bit different. So definitely with the uncertainty and kind of looking at what they actually needed, was a challenge for me. Working in a new environment, learning about how their ORs ran, how they got equipment, things like that. It was very different because specifically for even endotracheal tubes, blades, every equipment that they need to be checked out under the patient in the pharmacy in the supply room so they could be charged. There were a lot of cases that they were canceled day of because patients weren't able to afford their care. And so that was a big issue for me because I have a picture of a bougie here. We put a bougie above all of our machines just in case we encounter a difficult airway so we could use it. And they definitely didn't have that. There was also definitely a lack of equipment. Before I went, one of the areas of interest was inter-op teaching, and especially using the fiber optic, because they didn't have that type of teaching. And unfortunately, a week before I went, the fiber optic actually broke down, so that wasn't available. And I, unfortunately, in a week's time, wasn't able to coordinate bringing like a disposable fiber optic there. So definitely, all they had were the basics, endotracheal tubes, oftentimes not of the right sizes, no video laryngoscopy or things like that. So totally a foreign environment, which made it kind of challenging as well. So what I did was I did more teaching using interactive approaches, which is really what the residents wanted. So I did lectures, but I also focused on debates, games to simulate discussion and participation. I also gave them candy because that always gets everyone able to talk, and then case simulations and case-based discussions. And then another thing that I did, I brought some equipment over, especially because I know we have so many resources here. We opened up a ton of bougies and put them on both of our machines to have them ready for our case. And I brought some of the kind of unused equipment over. So, and I did a difficult airway workshop. So I met with the junior registrars, who were basically a CA2 equivalent. They didn't have their exams coming right up. And we developed a workshop together. So I did a lecture. We got mannequins in different stations. And I actually had the junior residents teach their colleagues specifically how to use a bougie, and then also I brought some air tracks so they could experience a video laryngoscopy, which none of them had, or a lot of them had not before in the past. So kind of, I think there are many opportunities for teaching in Zimbabwe, and definitely with this partnership and with CIGH, the Centers for Innovation and Global Health, I think there's going to be some partnerships in the future. And I think Rebecca also mentioned that Dr. Farai had come from Zimbabwe to kind of visit and kind of think about things that they can improve in their curriculum. So future directions for mentorship. Definitely, I think they needed additional video lectures as a supplement to their curriculum. They also want to further develop their simulation curriculum. So Dr. Fry, who came from UZEM in last August, he actually, when I went there in late August and early September, he actually had gotten a lot of equipment donated for their simulation. A lot of mannequins for medical students and residents. So definitely, and it's slated to open in 2016. So they're going to have a space available. So they're definitely looking to develop that curriculum. Another interest area that they have is that they want to develop fellowship training in country, which is currently not available. So in areas such as regional and pediatrics, currently they send residents that are registrars that are interested to other countries such as India to do these fellowships. And then I think one of the residents who have come back, who is now faculty, is really interested in implementing acute pain service. So definitely when I was there, and they definitely asked us about what kind of things they did and how they can probably integrate that in their system. And then definitely had a lot of fun. So I wasn't making lectures and giving lectures. The weekends were definitely possible for me to go travel around Zimbabwe. So went to Victoria Falls, one of the largest waterfalls in the nation. Got to meet an elephant. And I definitely liked and appreciated all my fellow residents or anesthesia colleagues in Zimbabwe. So definitely had an African barbecue with them at the end as well. So it was great. It was a great experience and a great time. I wanted to thank Dr. McGoldrick, Dr. Mole, and Dr. Crawford. They had been before to Zim, and they provided great guidance in kind of my trip that was going on. Dr. Shuma and Dr. Farai, they were at Zim and they were great hosts, and so I want to thank them. So I want to thank the Centers for Innovation and Global Health, CIGH, for kind of their funding of my trip, and also the support of Stanford Anesthesia and the Division of Global Health.
Good morning. I'm Lauren Steffel, and this morning I'm going to discuss my global health experiences as a CA3 at Stanford. In the interest of full disclosure, I won the resident jackpot when it comes to global health trips as a CA3. So this September, I traveled to Antigua, Guatemala with one of our pediatric anesthesia attendings, Dr. R.J. Ramamorty, on a pediatric cleft lip and palate mission. In February, I traveled to Kigali, Rwanda with Dr. Anna Crawford, one of our adjunct anesthesia attendings, in a trip that Dr. Miller will be detailing this morning. And then I spent the month of March in Ho Chi Minh City, Vietnam, on a trip that I'll be detailing this morning in my talk. So So a little information about the fellowship with which I went to Vietnam. It's entitled the Society for Education Anesthesia Health Volunteers Overseas, or SCAHVO for short. It's a 4-week experience, it's ABA accredited, and it's an educational mission, so it involves didactic and interoperative teaching. When I applied, the year I was applying, there were various sites that were available. They change year to year, and in my year they were Vietnam, Ghana, and Malawi. And funding is independently funded through SCAHVO. For the residents in the audience who might be interested in applying, it's through the SCA website, which is pictured here. The deadline is typically late January, and the application involves a letter of recommendation from our program director, as well as a letter of intent with emphasis on past global health experience. So where I worked in Ho Chi Minh City, I was lucky enough to work with a group of anesthesiologists, so MD equivalents, as well as anesthesia assistants. And some of them are pictured here. The hospital I worked in was in District 5 of Ho Chi Minh City, an 8 million person city. And you can't tell from this picture, but it's on this busy, bustling street. There are lots of motorbikes going by, and they're very prepared to deal with the motorbike accidents because this is the equivalent of a hospital for special surgery of Vietnam. So they focus on and specialize in and are limited to orthopedic surgery only. So my teaching duties were twofold. First of all, I would give didactic teaching before first case OR starts, as well as interoperative teaching. And the reason behind this is that many Vietnamese anesthesiologists go straight from medical school to a job. So there's a lot of on-the-job learning, and they felt like there was some didactic experience that was lacking in their education. The topics that I presented in the morning were areas of interest that were presented to me by my Vietnamese anesthesia colleagues. And as you can tell from this picture, there were significant language barriers. So most team members, including the physicians, did not speak English. I do not speak Vietnamese. And so my presentations were translated daily and very graciously by my Vietnamese anesthesia colleagues who spoke English. As interoperative teaching, areas of interest presented by the team to me were technical skills. We focused a lot on ultrasound-guided arterial lines, fiber optic intubations, glide scope intubations, and this leads me to my clinical case. I selected this case because it involves clinical as well as ethical and cultural issues. So here's actually a picture of this. It's my first week in the hospital, and I'm teaching Dr. Liu, who's pictured here, how to perform her first glide scope intubation. The patient's healthy, pre-oxygenated, has a straightforward airway exam. And watching us here on the left is Dr. Duke. He is the director of anesthesia at the hospital, and unfortunately we have no language in common, so I'm not able to communicate with him. So as Dr. Liu is placing the glide scope blade in, trying to find a good view, as many of us do, she struggled with her first glide scope intubation. And when she hesitated, Dr. Duke quickly took over the procedure. At this point, without taking his eyes from the glide scope screen and using what to me appeared to be more force than usual, he performed the glide scope intubation. And because the procedure looked unusual to me, I went back in with the glide scope blade in the patient's mouth and saw that the endotracheal tube had gone through the tonsillar pillars. The patient had sustained a tonsillar tear. Now, let me ask, if this happened to you, if this happened here at Stanford, what would your next course be? What would be your next step? Yeah, I completely agree. So I actually took care of a patient who had sustained a tonsillar tear. And his course involves a complex reintubation, ENT repair, a week-long period of intubation, antibiotics. In short, this is a complicated, complication, if you will. So the first thing I do is I ask for an ENT consult, and I'm told, this is an orthopedics-only hospital. Unfortunately, there's no ENT. So my next question, well, can we keep the patient intubated until an ENT consult can come, even if it takes several hours, takes a day? And the answer I receive is, there's no ICU capacity. The patients can't stay intubated. Now, next I drew back on my knowledge of how the hospital works. So how are patients typically extubated in this hospital? So from what I had seen in the past few days, remember this is my first week, patients were brought to the PACU, intubated, placed in 4-point restraints, and extubated by a non-MD, non-RN technician when they were deemed to be fully awake. Now for this patient, this is not a safe mode of extubation. So we're standing in the OR. The case is finishing up. The suction, as you can see, is has a lot of blood. What are the available resources in your hospital? How can you express your concerns for this patient's safety through the language barrier? And importantly, in a medical system that is hierarchical and this complication is from its leader, who is it most efficacious to express your concerns to? So I can tell you what I did. I had the patient extubated in the operating room, not in the PACU. I had all the airway devices available in the hospital around us for extubation. The patient actually was extubatable and did fine, and an ENT consult was arranged after I spoke with the former director of anesthesia at the hospital, who spoke English and I was able to communicate to, and who was also a very senior member of the department. So my personal learning tips from my trips are, number one, just as you would in any hospital in the United States, know your resources, seek help from culturally appropriate sources, and very importantly, any experience is a collaboration between you and the site. You may have honed the best teaching techniques that are relevant within your medical culture and within your area of expertise, but it's really up to both sides to be flexible for a good experience, both for education as well as patient care. Finally, I want to say I really enjoyed myself on this trip. I made friends, I got the chance to travel, and thank you very much to Dr. Pearl, Dr. Mercario, and the Stanford Department of Anesthesiology for their support.
I get two?
Yeah.
Good morning. It's nice to see all of your smiling faces once again. I'm going to be discussing the elective as outlined by Anne regarding Rwanda, which I had the good fortune of going in February, March of my CA3 year, and then again in October and November of this year of my fellowship year in pediatrics, which was fantastic to see a lot of the same attendings as well as the same residents, a little bit more senior, a little bit more knowledgeable, along with the new CA1 class that was started. This program takes place at the University Central Hospital of Kigali, which the educational program I was a part of is under the direction of the Canadian Anesthesiologist Society International Education Foundation. Since 1996, this organization has been going globally to provide anesthesia education to residents, attendings, fellows, anesthesia technicians around the globe. And Stanford presence there has been at least over 6 years, and annually has occurred since that time. Primary focus of this trip is education. This is not a program which I think is one of the best parts of the program, which displaces anyone's work from where you're going. The attendings are still assigned to the hospital, to the cases. Typically, one Rwandan anesthesiologist will cover OB, the ICU, as well as the ORs every day. One. So if you talk about double covering, this is, times 20. But has the opportunity as residents and as fellows and attendings to go and really serve as intraoperative as well as didactic teaching operatives for this month. There's broad case exposure. You'll see things that you will never see here, both due to social and economic issues, to the trauma that is witnessed there, as well as to the pathologies that develop. The other thing I would say is your impact factor by going on a trip like any of these, and particularly I think this trip in Rwanda, is that for a population of about 12 million people, there are approximately 20 anesthesiologists in the country. Majority of the anesthetics are provided by anesthesia technicians, which are high school graduates, which then have 3 years of anesthesia education under the direction of anesthesiologists in the hospitals. Every year, unlike here, there's no guarantee that the anesthesia class fills. And so for the CA3 equivalent year, there are 5. residents for the country. The year below that, they did not have any anesthesiologists matriculate from residency. The year under that, the equivalent of a CA1 year, there are 2. And then the year that just started when I was coming on in September, there were now 12 new anesthesiologists. So to help educate the next generation truly of anesthesiologists in the entire country. Lauren was able to go for 2 weeks to this experience for the residents thinking about taking this particular trip, and there's also a 4-week option as well, which I was able to do twice as mentioned. This is Monday morning. Usually starts with morning report, where the team from the overnight explains a difficult case, which is then moderated by the resident and the attending that's in the case. In this case, Megan is going through some morning report topics. I think I have an EKG lecture pulled up. The nice thing about this group over the last few years is that where it used to be mostly directed by visiting attendings, visiting residents, an issue that this country faced, this hospital faced, is that whatever volunteer was kind of coming through, whatever their expertise was, that's what was taught. So a lot of the residents I asked, what topics have you learned? And they mentioned they learned how to do, acute pain blocks like 6 times during that year. And I said, well, what about pediatric anesthesia? What about EKG reading? And they're like, no, we didn't have any experts on that. I said, well, I'm certainly not an expert on that, but I can kind of teach you some topics that are a little bit different. The nice part about this program, as I was mentioning, is that there's a set didactic curriculum that has now been set between the organization, CACF, as well as the hospital. So that every month when a group of new volunteers comes in, which happens on a 4-week basis, the curriculum is set throughout the year, and so nothing is retaught. Whatever topic you're assigned to, you have a few months to prepare for, and then help lead these Monday sessions in collaboration with local residents and attendings. Just a sample of the case load October through December. October, we were on respiratory physiology. Francoise was our resident teacher. We had a preceptor for that. We had a topic to cover. We had a resident teacher who was focused on a different issue, a medical student teacher, a case presentation, and then an activity. So this was every Monday. 7:30 morning report started. Our day usually finished by 4 p.m. with an hour for lunch break. So a lot of didactic teaching throughout the day that is led by the residents. So they're almost asked on a weekly basis to prepare 1 to 2 hours of material for their fellow residents, as well as for med students and the technicians in training. For the CA, now thinking back to my days as a CA1, now that I'm all wise and aged, I used to have to do paper records. Many of you don't remember having to do this. You'll have that pleasure by going to Kigali and working on your paper record on the left. Drawing up meds in the morning, many of the same things that we do are obviously done there. Different medications, typically fentanyl, morphine, propofol, and vecuronium are used, as well as halothane and thiopental. This is the dream machine. Less of a dream to work with than you might expect from the brochure. Oftentimes takes several monitors, several different pieces of equipment in order to get all your vital signs. They had 3 pulse oxes typically on each patient. One would usually work. EKG tracing was pretty good most of the time. I went in and explained to them smoke over fire, air over grass, and they said, the EKG tracing looks a little bit different, Dr. Chris. And I said, no, this is the right way to do it, guys. This is the right way to do it. And then I soon realized that it was a European EKG lead model, which is not done in that fashion at all. They were right, and I was terribly wrong. So, ST depression explained. For those of you who just went through the match and the draft, I guess, for your CA3 year, I hope you have ENT as part of it, or if you've not already done it, you're able to do it before you graduate. Along with the trauma, along with the pediatrics cases that we were able to do, which included TE fistula repairs, pyloric stenosis, Hirschsprung's disease. significant amount of ENT cases. Once again, due to social and economic factors, things progress a little bit further before intervention than we are likely to see here in the States. This was a enlarged thyroid that needed to be taken out with a tricky airway. A lot of deviation to the right, and so we were able to scary to see these CT scans prior to intubating the patient, but giving a lot of attention to preoperative planning, what we could do, what our plan A, B, C, D, E, F were in this case, and taking the residents as well as the attendings through that. After intubation, and then a 4-year-old with a cystic hygroma that also proved to be challenging for all involved. As Ann and Lauren pointed out, have the opportunity to teach new techniques. I think this was the GI scope that we were able to acquire somehow through bartering. We're able to get this and do some fiber optic techniques as well as education on preparation of difficult airways. And just a shot of the OR. We were able to teach a lot of residents that are at each hospital. There are 4 hospitals that they typically work at, and you as the resident are able to go between all of them, between Seashika, which is in Kigali, Seashu Bay, which is in the former capital of Butare, as well as a military hospital in the city of Kigali and a private hospital. All of the residents rotate there just as we do through our sites, and this particular day is the private hospital doing a general surgery case, and we were able to teach both the anesthesia technicians that are with us that day as well as the CA1 residents who are very eager to learn. This is a shout out to Dr. Ryan Derby for teaching me how to do an interscaling block and then trying to teach our attending colleagues in Rwanda how to perform this. New ultrasounds were received by the department, and so their favorite thing is to attempt. This is a PACU block, rescue block, that is being performed for shoulder trauma. But we're able to do a lot of fun teaching with new techniques and old ones as well. This would not be a Stanford rotation without simulation involved, and so this is our simulation mannequin that I think Lauren had a picture of as well. We were able to do some mock codes with this individual, as well as teach the residents, attendings, and have a display for the Ministry of Health that came by that helps to continue to fund this simulation program along with the Canadian Foundation. Thumbs up for ACRM. First time they'd been taken through the wheel, and it was very effective, very fun. And I think they found, even though the mannequin looks a little less hi-fi than what we have downstairs, they found it to be quite a real experience, I believe. Month concluded by teaching in an OB SAFE course, safer anesthesia from education, that was taught at Ruhengeri Hospital, about 2 hours from Kigali. This was a course for nurses, anesthesia technicians, MDs, trainees in the work of OB anesthesia, in resuscitation, in spinals, in airways. Allowed us to use some of the medications that are mentioned in the Hall book while studying for the ITE that you said, I've never used this before. You will get to use these medications here. And just some shots of the neonatal resuscitation that we went through as part of the OB course. And then our case report is the first male in Rwanda who was pregnant, and was able to walk him through what we would ask prior to placing a spinal. I think this friend was one of our anesthesia technicians there, whose wife just had a baby, so he got to experience that for himself. You'll meet friends, both large and small. This little guy helped me with multiple intubations, and you're going to have a great time. It's very, 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 very beautiful country, very, very welcoming people, and a wonderful experience. So just tips, more for the residents, in terms of how to prepare this, how to plan going forward. Know when the trips are. Thanks, Chris. That's great advice. But you can't go unless you know. So make sure that you guys know, sometimes even a year out, who's going on what trip. Now this changes a lot, and some of the opportunities, as Lauren was mentioning, are just kind of luck of the draw in terms of what you're on when these occur. But as much as you can, plan, and now that we have a lot more established programs that are going throughout the year, know when the trips are. If you're on an elective or a GORE month during this time, there's a little more flexibility in being able to go on these trips, especially ones that are more short notice, and start planning right now. A lot of times peds anesthesia will be very, very useful on these trips, as well as regional. And so if you can get both of those before you're able to travel abroad, I would highly, highly recommend that. And a few of the sites as highlighted today, and others on the pin board. Thank you very, very much.
And all but 3 hospitals use non-physician anesthesia, largely because there are only about 12 to 14 ND anesthesiologists in the country. And that number was probably the nadir from a year or 2 ago. Now that Black Lion's anesthesia program is back up and running, but the bulk of anesthesia is provided by anesthetists and master's anesthetists providers, and the anesthetists go to training right after high school, and then they go practice for a couple years, and then if they're basically institutional lets them, then they can get additional 2-year training in master's anesthesia. And as we talked about in many of these other sites, there's not only limited medical supplies available, but also general infrastructure like electricity, clean water, and transportation. So the hospital we were at was called Cure International, and it was funded by the NGO Cure International, and so that meant it was very well equipped by local standards. It had 4 ORs, it's expanding its building, and it has 2 U.S. boarded anesthesiologists on staff and 3 anesthetists on staff, and then it's also a training site for 4 anesthetist master students at a time, and 0 to 1 anesthesiology trainees at a time. The doctor who was the liaison with the ASA program is Dr. Mary Bernard, who's the head of anesthesia there, and recently, as the other anesthesiologist from the U.S. came, she was promoted to the medical director, is able to split her time a little more effectively. So this is a picture of our anesthesia machine and our drug area. As Chris mentioned, a lot of times the machines need a little extra monitor add-ons. The pulse oxes were those life boxes. Everyone got one of those, and then there was one entitled CO2 monitor, or actually 2, that we kind of rotated amongst the ORs where they were kind of needed most. And we also used more fentanyl and morphine. Not everything is different from here. They also ran on glyco while I was there. And the rest fairly well equipped. Airway equipment, everything was reused. They did have some LMAs, but you couldn't rely on them to have the size and the amount of air you could inflate on them. So you actually had to know those amounts and how to estimate the size appropriate for the patient. And they did have a mess of tubes lots of ENT teams had come and brought oral rays and everything. But unfortunately, someone had cut all the cups off the 4.0 oral rays. So for when the visiting ENT teams came, you either had to size down or size up or use a non-ray tube, which was a little frustrating because they were there, somebody had just cut the cups off for some reason. And something that made Cure a little different than other hospitals in the area is it had a PACU that was staffed by nurses, which was just very reassuring. But the anesthetist students said that in other areas you just had to bring them to the PACU and leave them there, or bring them to their room if they were going to be hospitalized, or have family members watch them. And then since everything is reused from endotracheal tubes to the oxygen masks, there are a lot of cleaning supplies. You wash them and then you hang them up to dry or put them in a dryer. And then when they're dry, you use them again. So my rotation consisted of giving lectures and also clinically based teaching. We mentioned it's a rotation site for both anesthesia residents and anesthesia master students. For the anesthesia residents, the site is mainly where they learn regional anesthesia because there's an ultrasound machine there. And then for the master students, it's where they focus a lot on pediatrics in addition to regional. So as Chris mentioned, it's really useful to have done regional and pediatrics before you go. And I actually hadn't done regional before, and so there was some on-site learning for me as well, other than the few blocks I had done on pediatrics. And then on Friday, you give lectures for the whole master's students class, and there are about 20 or so students who come from various sites. And it's 3 hours in the morning, and Mary, Dr. Bernard, has a curriculum that sometimes changes a little bit because you have to make up ones from prior weeks where they didn't have lecture. But there was fairly good internet in the guest house, and so you could revise your lectures if you needed to. And they have a small anesthesia textbook library at Cure as well. This is the guest house where we stayed. It's about a mile from here. You just walk back and forth. It's fine, which is good because other transport is very difficult. The roads don't have names that everyone knows. It depends kind of where you came from, what you call the street, and it's difficult to communicate locations. You like name a nearby landmark, which there may be 5 other Michele churches in the city, and that's a problem. And they also give you one of the brick cell phones. You can remember how to text with the buttons, which is good because this is the public phones. And since Cure is very well equipped, it was nice to be able to visit the other, some of the other hospitals in the city to kind of get an idea of how care was provided in most of the rest of the country. And so Black Lion is the main teaching hospital in Ethiopia, but it's had some trouble recently. Their Department of Anesthesiology actually closed for about 8 years in the mid-2000s and recently reopened, as we mentioned. So now hopefully that number of physician anesthesiologists is increasing in Ethiopia. And a large part of the hospital is still closed because they're cleaning out the asbestos, and it's funded by the Department of Education, which doesn't really have, it's not really a priority given that a large proportion of the population needs basic education. So St. Paul's has seemed like it's kind of filled that void, and it's recently expanded a ton. They're funded by the Department of Health, which just focuses on health, which is beneficial for their funding. And they also have lots of money from foreign donors. And it's interesting that their anesthesia department is actually run by a graduate of the anesthetist master's program. So there's a little bit of institutional, not institutional, but people at different provider levels conflicting and not necessarily communicating as ideally. Then I also got to go to Menelik 2, which is just building a new building, as you can see, and they have some oxygen pipelines, which is exciting because I think it's the first place in the country to have piped in oxygen, and Black Lion trainees are going there too. And we had fun outside the hospital as well. There's amazing museums in Ethiopia and great food. And Christina was a little more adventurous than I was because I was pregnant. But she went to Lalibela, which has just great buried temples, and then also to Tanzania and Kilimanjaro. She piggybacked her vacation week at the end of it. So thank you very much to the whole department and the ASA for funding and putting together this rotation, and the doctors I worked with in the country and the anesthetists at Cure Hospital, and everyone who was very welcoming at the various sites that we visited. I think that somebody's going to...
Thanks everyone for your very interesting presentation. And just to end with a sneak peek on what is happening within the division of global health and in the department. As Rebecca mentioned, next year we do have Dr. Harder and Ross going to Ethiopia, so congratulations to them. So this program is holding strong within the anesthesia residents here. The Rwanda rotation is going to be in February of 2017, and the Zimbabwe rotation is going to be in March. So if you're interested, please let us know, or if you have any questions, please ask us. Some exciting things happening within not only the anesthesia department, but with our surgical colleagues. Dr. Sherry Wren has started this Stanford Interdepartmental Surgery Center, which should be a collaboration amongst anesthesia, surgery, and other departments to hopefully work at sites internationally together, so departments working together instead of in silos. We're working on a possible bi-directional exchange program with Rwanda, as in not only do we go to Rwanda, but Rwanda residents and other anesthesia providers possibly come here. That is in the works. As Rebecca also mentioned, the survey that Michelle did with medical students applying to anesthesia residency here indicated that there is strong interest in global health track. So that's something that we may be looking into for residents in the future. Also very early on, but exciting things that could be happening. And outside the department, if you're interested in global health conferences, there is the World Congress of Anesthesiologists that happens once every 4 years. So this year it's in Hong Kong. It's a great place to network within the field of global anesthesia with other providers from across the world. There's the Bethune Roundtable in Halifax. And then there's a very interesting course on anesthesia for global outreach and doing anesthesia in austere environments at Boston Children's Hospital in the fall of this year. So thank you very much for listening to what's been happening in the division. And if anyone has any questions, we're here, or we're always available to answer questions about global health and